Hey everyone. This presentation is focused on rational prescribing. Now, rational prescribing is the way that we're supposed to prescribe anything that we prescribe as medical doctors or as healthcare providers, but it presents a unique approach to an evidence-based integrative medicine philosophy that I think is an important way forward at a time when this discipline or this approach to clinical practice is more and more criticized and polarized in a climate where evidence-based medicine is becoming the dominant paradigm for healthcare. So I call this outcomes-based integrative medicine. Now I'll show you why. So evidence-based medicine is the dominant paradigm in healthcare. Payers and thought leaders in the profession rely on evidence to guide recommendations for how we should look after any patient with any problem. And physicians and other stakeholders criticize integrative medicine primarily because it lacks evidence, or so they say. Of course, there's a lot of evidence to support many of the therapies that fall under the umbrella of integrative medicine. But for many frontline doctors and other healthcare providers, there's this notion that a given treatment is either proven or it isn't. And the vast majority of CAM simply does not meet the standard of evidence-based medicine if you consider level 1 evidence to be that standard, meaning several large, well-conducted, double-blind randomized control trials or a systematic review or meta-analysis of all the literature that concludes that something is certainly effective, better than placebo in a large population. So integrative medicine will never be accepted by healthcare systems under this paradigm. And my interest is in seeing more people have access to options when guideline-based care simply doesn't deliver the outcomes and the satisfaction that they need in order to feel that they've achieved their wellness goal. So, unfortunately, I will be reading my slides, but I promise that the comments will make them worthwhile. So who am I and why is it important to listen to what I have to say, and what are my potential conflicts? So I use a rational prescribing approach in my integrative pain management practice every day. I provide recommendations based on what I think patients might benefit from, keeping in mind their specific circumstances, their needs, their goals. I let them make the decision. And when it comes to chronic pain, as most people recognize, the guideline-based treatment recommendations are rarely enough to help people return to a meaningful level of function and quality of life. I've published evidence-based reviews of natural health products for a wide range of common conditions in a journal called Canadian Family Physician. I co-authored a chapter in the Canadian Diabetes Guidelines on natural health products. I was an investigator in the trial to assess chelation therapy and observed the outrage that it caused among cardiologists at the American Health Association meeting. And I've undergone a number of investigations from my regulator that I think were tainted by negative bias, which is understandable and present in every jurisdiction. It's something that all doctors have to deal with when they're making the decision to include these therapies in their regular practice. And I'm working on a project to develop a data tool that will collect outcomes data at the point of care for prescribers, therapists, and patients. So what is rational prescribing? This is an approach to prescribing any treatment that is recommended for all interventions. But unfortunately, because modern care is so busy and overloaded with requirements to meet standards and see patients with volumes needed to keep an operation going, the rational prescribing steps are rarely followed completely. Observational data is recognized as a useful complement to randomized controlled trial evidence. This is important to recognize, that a double-blind study doesn't tell us everything we need to know. There are sources of bias that apply to clinical trials. There are limitations that prevent trial outcomes from being seen in the real world. And this kind of real-world data, so-called observational data, can add to and enrich the evidence that we have from RCTs. And of course, just because something was better than placebo in 10,000 patients doesn't guarantee that it's going to work for an individual in your practice. So what we call N of 1 trials for an individual patient actually represents the true gold standard for what we would consider real-world evidence. It's effectiveness in that patient. And so this allows for a more targeted selection of long-term interventions to minimize cost and patient burden. It allows an individual patient to identify what worked for them and continue using what works and stop using what doesn't. It creates a platform for integrative physicians to be embraced as evidence-based providers, true members of the community of the profession of medicine. Of course, there are a number of forward thinkers and mavericks and early adopters and innovators who fall under this umbrella of integrative medicine. And in many cases, they don't feel as though their colleagues, their regulator, the stakeholders who pay for global healthcare systems really appreciate the work that they do or value the outcomes in their patients. And so, of course, this creates a platform for broader acceptance and use of integrative healthcare in general. We can begin to see where integrative medicine might fit in the practice of medicine overall. So an example would be a patient from my practice who we'll call Brian, 55-year-old gentleman who's on disability pension, slipped on the ice while getting out of his truck 5 years ago, suffers from chronic low back pain, from migraine headaches, fatigue, constipation. He's taking a number of medications with really minimal improvement in his symptoms or his function. And he wants to get off his medications and try alternative approaches. This is really important to recognize, that most of the patients who seek care from an integrative doctor are specifically looking for that. They've already exhausted the guideline-based interventions that most doctors can provide, and they're looking for something different. So the World Health Organization published a document called the Guide to Good Prescribing several years ago. And that document is still the reference for rational prescribing that is used by many of the medical schools and postgraduate training programs that train doctors to prescribe anything, whether it's a drug or a lifestyle intervention or a natural health product or a procedure. So the steps are to define the problem, identify what you're trying to treat, clarify the treatment goals. What specifically are you going to measure or observe over the treatment trial? Select a treatment, write a prescription that structures the treatment and clarifies how they're supposed to take it, how often, for how long, etc. Provide information, instructions, and warnings that's specific to any one treatment. And that requires knowledge about the treatment and experience with having prescribed it, and also evidence when it exists. And of course, monitor treatment and make decisions based on whether it was effective or not. So forgive the animals, they add some humor. I hope you enjoy them. We recently got a puppy and they're just adorable. So define the problem, step one. So this can be a symptom or a sign. It could be a disease or a disorder. And of course, this requires a proper medical assessment, including a history of symptoms, past medical history, physical examination as indicated, laboratory testing, imaging, specialist consultations. Most patients who seek out an integrative provider have already seen a dozen doctors, have already either had a diagnosis or been given 10 different diagnoses. But of course, it's important to ensure that nothing's been missed as part of this assessment, and that's part of good practice. So that includes a list of current treatments and previous treatments to ensure that guideline-based care has already been tried, or that patients, for whatever reason, prefer to pursue a different approach. Step two, clarify treatment goals. So if the goal is to improve a specific symptom or modify a disease marker like cholesterol or hemoglobin A1C in the case of diabetes, if it's eliminating unpleasant or potentially harmful drugs, so reducing the need for anti-inflammatories or anticholinergics, which can have an impact on brain function in later life. In some cases, the goals are functional, to be able to do something, whether it's work or caregiving, spending time with kids, riding a bicycle. Everyone has different goals that matter to them. In some cases, it's just ability to cope with a problem that we can't treat. And that may translate to a goal of simply a better quality of life. And of course, when you're setting goals, you want them to be specific, measurable, achievable, realistic, and time-based. And there are a number of YouTube videos about goal setting. Books have been written on the subject. But most seasoned clinicians should be able to structure a treatment goal into something that is smart. So, for example, reduce migraine frequency to less than 3 per month within a 3-month time frame. Step 3, select a treatment. And so, of course, in most cases, you want to start with guideline-based care when it exists, if it hasn't already been tried. And you can select other interventions when guideline-based options have been exhausted or when patients explicitly state a different preference. So you can discuss options with patients, and in some cases it will be based on finances. In other cases, it will be based on their schedule. In some patients, a specific treatment helped a neighbor or a loved one, and they really want to try that first. And so those are all valid reasons to consider trying one thing over another. And as a provider, your experience and your skill in managing these problems and having a number of options in your toolkit is what allows you to advise patients more effectively when they do this. So, of course, if there are alternative treatments that have some evidence to support their use, you would consider those higher on the list. Step 4, write a prescription. And that usually includes a date, the patient's name, the prescriber's name, your signature, and when relevant, a license number. This is what we need to provide to a pharmacy in order for the pharmacist to be allowed to fill the prescription. The key is that you document the name of the intervention. So if it's a diet or a lifestyle change or a natural health product, you want to clearly indicate the name, the dose or strength, the frequency, and the duration. So, for example, if you're considering melatonin for sleep or brain health, you would recommend 1 milligram sublingually at bedtime every 15 minutes until you fall asleep for about 7 days. Some additional advice can be provided to patients to help them navigate that trial, but in my experience, that's usually adequate to determine whether melatonin is going to be helpful or not. A gluten-free diet, for example, would need about 3 months to improve symptoms of irritable bowel syndrome or any of the other chronic conditions that may be linked to non-celiac gluten sensitivity. Massage therapy. You would prescribe a specific provider because every provider is a different intervention. When it comes to massage or acupuncture or chiropractic, we all know that no two people treat patients the same way. So it's kind of silly to expect that you would decide whether or not to recommend acupuncture based on whether a double-blind study says that it's effective. Because if there is an exceptional acupuncturist in your community who achieves excellent outcomes in your patients and has done so for a decade, well, that's important evidence to consider. If there's no one in your community, then you might think twice before prescribing that intervention. When it comes to something like Boswellia, I would recommend perhaps a specific brand because I know the dose and the formulation, and I've had patients use that product in the past. I know that this particular product is more absorbed when it's taken with meals, and I'll recommend 1 bottle of 60 pills. So that will last for a month. Step 5, give information, instructions, and warnings. So for Boswellia, confirm the brand if needed. Take with meals, may cause stomach upset. Observe for a slow, gradual decrease in painful joints. Those are some of the highlights that I would share with a patient who was going to try Boswellia for a month. Gluten-free diet. Segregate your groceries so that all of the groceries with gluten are in one part of your kitchen and yours are in another. Learn to read labels. Ask servers when you go to restaurants or takeout whether what you've ordered has gluten in it or not. If you're invited to dinner, inform your hosts in advance. Don't worry about putting them out. Just let them know that your doctor recommended it. So you have to follow those instructions. Insist that you're following your healthcare provider's advice to avoid peer pressure. And when possible, choose natural gluten-free foods rather than processed gluten-free foods. And of course, I tell patients that even a cracker can trigger reaction that can disturb their immune system for a couple of weeks. So it has to be a 100% strict adherence for that 3-month period. When it comes to therapists, I can say things like, choose someone near your home, discontinue therapy if it doesn't feel right, drink hot liquids, and avoid overuse of your body on treatment days to ensure the best outcome. These are examples of the kind of information that an experienced integrative provider can give to a patient so that they can more safely and responsibly explore complementary and alternative medicine therapies under the supervision of a professional rather than on their own. And finally, and most importantly, monitor treatment. So this is the step that's typically missed in many patients with chronic complex conditions that doctors struggle to address properly. Doctors often feel like their duty is to prescribe something, and they sort of cross their fingers and hope for the best. But in my experience, in many cases, medications that are ineffective are rarely deprescribed because doctors want to make sure that they're doing their job, and their job is to make sure that patients are taking something and that they're adhering to guidelines. But I would argue that in the 21st century, our primary duty is still to our patients. Even in an era of evidence-based medicine, it's more important to ensure that your patient is actually getting better. So has the patient been compliant with treatment? Was it effective? If not, why? Did problems occur? Is it sustainable? So if a patient tells me that a specific diet is simply not realistic for them, or if a patient can't afford a treatment that they've started that is effective, or if they have unacceptable side effects, or if it doesn't work, or if for whatever reason they simply don't want to continue, these are all reasons to discontinue therapy and try something else. So, of course, this is not the be-all and end-all. It's not the solution for every integrative medicine interaction, and it's not going to fully address the evidence gap that exists, but it's definitely a step in the right direction. So of course, this may require a little bit more time and more provider visits, but what I usually tell my patients is in a year, we can probably try at least a dozen things. And if 1 or 2 of them are helpful, we've made a long-term difference in your life. And if you do that over time, you'll develop a regimen that works for you, that includes a wide range of different therapies that you've chosen, that you've tried, and that you've decided are effective in your body. Now, trying one thing at a time will tell you whether something was effective or not, but there is something to be said for a comprehensive approach where you do everything all at once because the goal is just to get a person better. And I often tell patients that if your car is stuck in the snow and you need 10 people to push your car to get it out and to get you driving again, you don't really need to worry too much about which person did the most pushing. What you care about is that you're out of the snow. And so in some cases, that may be more appropriate as an approach, but it will leave you wondering whether you need to continue taking everything over the long term, which you should discontinue and which you should keep taking. And when things are expensive, that matters a lot. It may be considered a BandAid approach that is not true integrative medicine by those who really understand that integrative medicine is not just about applying a bigger toolkit to the same long list of diagnoses that every doctor uses. In fact, there's a problem with the paradigm of medicine, and many of the diagnoses that we still rely on are over 100 years old, and they're based on features that don't really make sense to separate. A good example is autoimmune disease, and there are more than 150 autoimmune disorders, but the root cause of the problem is the same in many cases. So if you have 100 people with multiple sclerosis, they can have that diagnosis for 10 different reasons. And if you have 100 patients with 100 autoimmune disorders, those may all be linked to an imbalance in gut bacteria or detoxification or emotional trauma or an infected wound somewhere in their body. My work is quite focused on blockages, which can be left over from previous injuries and traumas, where the nerves don't return to normal, the connective tissue does not return to normal, and restrictions in movement and irritable points in the nervous system can disturb the function of the immune system. And so this is an approach that may be more deep and effective, but is less approachable when you're talking about evidence-based practice. And of course, this approach may not be suitable for serious diseases or urgent needs or slowly evolving problems where you can't easily measure whether something is working or not. An example is integrative oncology, where if you're trying to determine whether one natural health product had an impact on your cancer, you may miss the boat, and a more comprehensive approach may be favorable in those patients. So again, that's a judgment call. It's between the provider and the patient to make an informed decision. What we call shared decision making is a key pillar of patient-centered care, and of course it applies here. So in summary, the idea is that rational prescribing is the way we should be prescribing everything in medicine, and emphasizing this approach when dealing with alternative medicine creates a door that allows integrative providers to really state with confidence that they are practicing evidence-based medicine. And this, I think, will allow integrative practice to take its place in global healthcare to address the needs of people whose needs are not met with the core assessment and treatment that makes up what we would call conventional medicine. So the process is to choose alternative approaches when guideline-based care has failed or is not appropriate, to allow patients and providers to assess and document their response to each intervention, to choose one intervention at a time and conduct a structured therapeutic trial around each intervention. And a one-year time frame allows serial trials of several different interventions. And so this may be more acceptable to the average physician who wishes to support patients without worrying about consequences from their regulator or from their colleagues who might consider what they're doing to be inappropriate in terms of the values of the profession, which in the 21st century are based on evidence first. And of course, hopefully, this will lead to less risk of discipline from regulators, which is the biggest barrier preventing patients from finding a doctor who's willing to do more for them than write a prescription. So in closing, it's worthwhile to note that at one time heroin was part of the pharmacopoeia of medicine, and that our idea of what is considered appropriate care evolves over time. And I truly believe, based on what I've seen in my patients, in my practice, that modern medicine needs to embrace integrative healthcare for the sake of patients who want it, and also because there are many diamonds in the rough in this wild west of alternative medicine. And if you think that there are thousands of options out there for patients to choose from, the probability that every single one of them is worthless is probably zero. So if you're a patient, I encourage you to consider adopting this approach. If you're a physician or a healthcare provider and you're looking for a way to reconcile this paradigm of evidence-based practice with your interest in complementary and alternative medicine and your desire to work with patients with these therapies, I would encourage you to give this approach a try. I think it's the best way forward for evidence-based integrative medicine. Thanks.